First polling question, are you currently suffering from shoulder pain? So if you could take a minute to answer that, it would be greatly appreciated. And we'll kind of compile those as we're going along. So, quick introduction, my background. I'm a graduate of Mount Sinai School of Medicine. I graduated in the year 2000. I stayed in New York City, did my orthopedic surgery residencies from 2000 to 2005, went on to do a sports fellowship at New England Baptist Hospital in Boston. And in 2006, came out here to the lovely Berkshires, and I've been here ever since. I'm a partner here at Berkshire Orthopaedics. So, osteoarthritis of the shoulder. So when we talk about arthritis, it's essentially what we refer to as the wearing away of the cartilage of the shoulder. The cartilage in any particular joint is what we call the articular cartilage, articulation meaning joint. And to give you a basic guide of the anatomy of the shoulder, if you look on the left-hand part of your screen, you will see the humeral head. That's the round ball part of the shoulder joint. And right here next to it is what we call the socket. We call that the glenoid. So this is what we call the glenohumeral joint. That is your shoulder joint. And cartilage is mostly water. So an X-ray beam will go right through that, and that will not bounce back. So the joint space, if you will, or where the cartilage lives, shows up as this black space between the socket and the ball. When that cartilage wears away in osteoarthritis of the shoulder, you get what you see here on the right. You get bone spurs that form because whenever bone is under increased pressure, bone reacts by making more bone. So you'll get bone spurs that form. You can get flattening of that humeral head. You'll get loss of that space, which is really actually cartilage, but you'll get loss of that space. And this is what a shoulder with osteoarthritis will look like. A lot of people ask me all the time, I've never heard of having a shoulder replacement. I always hear of hip replacements, and I always hear of knee replacements. And that's true. And it's obviously more common to have hip and knee arthritis. And the simple explanation and the simple reason for that is because we bear weight on our hips and on our knees, and we don't bear weight on our shoulders. So it is much more common in the general population to have symptomatic and painful arthritis of the hip and the knee. Who gets it? The same people that get arthritis of the hip and the knee. If you have the gene for osteoarthritis, or if it's something that runs in your family, the same people that get hip and knee arthritis can also get shoulder arthritis. Certainly people that have had a history of trauma to the shoulder can develop something called post-traumatic arthritis, or people that were overhead athletes their whole entire lives and use their joint a lot can have shoulder arthritis. Symptoms are the same as any other arthritic joint. It usually starts with a little bit of pain, achiness, almost feels like a toothache deep in the shoulder joint. And then that's typically followed over as time progresses. It's followed by, after pain comes stiffness, and then inability to do certain things. And in the end stage, you can actually have some crepitus or a crunchy type feeling in a joint as it catches, as the bone is rubbing against the bone of the joint. So that's the typical shoulder arthritis, osteoarthritis. The second type of arthritis of the shoulder is really something we call it rotator cuff arthropathy. Arthro meaning joint, and pathy, pathological, is when someone who doesn't have a rotator cuff that's intact, or a long-standing rotator cuff tear, the humeral head, which you see a normal picture again here on the left, the humeral head will start to migrate up and in. And that will it can actually wear away the undersurface of the acromion, and the acromion is that top part of your shoulder here. So the humeral head can migrate up and in and wear the upper part of the socket and wear away the acromion. Again, we call that rotator cuff arthropathy. The physical finding in folks like this is they'll notice a decreased ability to lift their arm over time. and they'll have a lot of pain, similar pain to regular shoulder arthritis. But obviously you can see this is a different wear pattern than the arthritis that we saw on the previous slide. So again, this is a wear pattern for regular osteoarthritis, and this would be the wear pattern for someone with advanced rotator cuff arthropathy. So just real briefly about the rotator cuff, these are the tendons of the rotator cuff, and I don't need to name all the tendons and go through that with you, but as these tear, that can cause that pattern of migration of the humeral head migrating up and in because these tendons have torn. Imagine, if you will, here, this is an example of the supraspinatus tendon that is torn in this person, and now the subscapularis, one of the rotator cuff tendons, is starting to tear. And over time, if this isn't addressed, you can imagine the humeral head migrating up, up superiorly and medially into the socket and up towards that acromion bone. And that can lead to rotator cuff arthropathy. So, non-surgical treatment for these types of conditions. Well, we can modify our activity first. So oftentimes we have people, as this is developing, they switch from being regular tennis players to now they're taking up more golf. Or if they were playing something like tennis several days a week, now they're playing once a week and they're trying to do something else the other days of the week, giving themselves often a day of rest. So it's modifying your activity. It's also cross-training a little bit and giving your arthritic shoulder some time to rest in between. I can't emphasize enough icing. I feel like icing is one of the most often overlooked treatment modalities, which is probably the most effective treatment modality. But it requires a little bit of homework and a little bit of prep on a patient's part where, okay, I know I'm going to be doing X, Y, and Z, and it's going to be causing my joint pain. So you got to be prepared to go ahead and put that ice pack on, wrap it with an ace bandage, and do that for a solid 40 minutes or an hour after you play. Often people will use NSAIDs, things like ibuprofen. Personally, I'm a big fan of Tylenol. It's not as hard on the body, and we've all obviously heard side effects of things like taking too much ibuprofen. It's not great for the kidneys. So, but NSAIDs, Tylenol, those are certainly things you can do to help control the pain in an arthritic shoulder. Injections. I'm not a big fan of multiple cortisone injections, but certainly a cortisone injection provides significant short-term relief. We don't like to do multiple repetitive injections over time because that can wear away tissue. It can cause further damage to the cartilage of the shoulder or to the rotator cuff. So a cortisone injection here and there is certainly something that is offered to patients. These last two categories of injections, this one called viscosupplementation, a lot of times people hear them referred to as gel shots or lubricant shots or artificial synovial fluid. They're also known as hyaluronic acid injections. For the shoulder, these are approved by insurance, by Medicare and certain insurances, but very often it's a battle with insurance companies to try to get them to approve shots such as these. And in order to get them into the shoulder joint, we typically need to use an ultrasound machine or a fluoroscopy machine, which just is a fancy x-ray machine, to get it into the joint. The literature and the results for these viscosupplementation shots is very mixed. Some people swear by it and some people feel like it really didn't help them at all. So that's why it's kind of challenging for getting insurance companies to improve them, because we don't have really good evidence-based, well-done literature that proves that it's an effective modality. The downside, though, other than the cost, the downside is relatively low. There's really no harmful side effects. The final injection here is something called PRP, or platelet-rich plasma. That's a little more involved of an injection. Again, not covered by insurance companies. In these situations, we take a person's blood and we spin it down in a centrifuge, and it gives us a very dense plasma that has all of the healing factors. And the theory behind that is then you inject it into the arthritic joint and it will give some pain relief. Again, there's no literature that really supports long-term pain relief past a year. There is some literature on the knee, in the knee arthritis literature, where PRP has been shown to be beneficial over, say, a cortisone shot at a year out. Again, my feelings are kind of mixed in terms of feedback that I get from patients. It is an expensive injection to do so. That is the downside. Side effects, not really any negative side effects to having a PRP injection. So time for polling question number 2. So have you been told that you need surgery or joint replacement for your shoulder? Go ahead and get that posted for you, and we'll appreciate any feedback that you have on that. So let's switch gears a little bit, and let's imagine a scenario where you have osteoarthritis of the shoulder. You've tried everything, you feel like you've exhausted everything, and I definitely encourage people to exhaust everything before they just jump right into surgery. And we'll obviously talk about expectations and limits and et cetera in just a few minutes. But if you're someone who's exhausted all options and you can't stand the pain and the shoulder's just not doing well, so for regular osteoarthritis of the shoulder, we have shoulder replacement. And in the traditional shoulder replacement, as you can see here on the left, we replace the patient's ball with an artificial ball, and then replace the patient's socket, which is plastic, so you don't see it on x-ray as well, but we replace the patient's socket with a plastic socket. This one on the left is an older design, more like a version 1.0. There are newer designs out there. This is an example of a design I'm using currently, where, as you can imagine, if this person were to need a revision surgery down the road versus this person, this would be a lot easier to revise and operate on than imagine what it involves taking something like this out or revising something like this. So this is more of a bone preservation surgery where the artificial ball is replacing the patient's arthritic ball, and then the plastic socket you can see here, and then they have these little radio-dense markers in the socket so you can monitor that over time. So this is what we call an anatomic shoulder replacement. The ball replaces the ball and the socket replaces the socket. And let's switch gears here a little bit. And now we'll talk about what we call a reverse shoulder replacement. And the reason we call this the reverse shoulder replacement is because the socket is now on the patient's ball side. And as you can see here, we've put a ball on the patient's socket side. So on an x-ray, it looks like this. Here, what once was the socket, we've now put a ball. And what once was the ball of the patient, we've replaced it with a socket. Why do we do this? We do this for the people with advanced rotator cuff arthropathy. It's what we call a salvage procedure, meaning once we've gone down this road, there's not much else we can do for a shoulder. It changes the physics of the shoulder. It changes the center of rotation of the joint, and it takes the requirements of the rotator cuff away. So if someone has a good functioning deltoid and bad rotator cuff arthropathy, this is the operation. It now it's very, very successful at giving people back pain-free elevation to their shoulder, and it relies on the deltoid muscle. So we don't have to rely on a rotator cuff, because in people like this, they don't have a functioning rotator cuff. So let's talk a little bit about what you can do in order to prepare for surgery. I kind of listed 3 things here: healthy lifestyle, being mentally prepared, and mobilizing the appropriate resources. And let me just expand on each one of those a little bit. In terms of healthy lifestyle, I tell people, this is time for you to be physically and mentally prepared for the surgery. It's a great time to get your diet as healthy as possible and as optimized as possible. A sleep schedule, as good as you can get your sleep schedule. Also, if you're someone who has high blood pressure or high cholesterol, anything like that, this is the time to kind of make yourself as optimized as possible for surgery. And if I didn't mention it, I apologize. Smoking cessation is very, very important. being mentally prepared for the surgery really means educating yourself, asking as many questions as you need answered, and really making sure that you're prepared for the recovery, because once the surgery is done, you need to be able to commit to doing the physical therapy, following the appropriate protocols, and making sure that you're committed to the process. In general, these processes of recovery are several months. It's not as something that is over and done within a week. So you really want to make sure you're mentally prepared. And that's a good segue into mobilizing the appropriate resources. We like to have someone who's what we call a coach. And that coach can be a spouse, it can be a close friend, it can be any family member. But we like to have people mobilize a coach that can really help them with things as simple like transportation. Some people need meal preparation, a few meals to be prepared so that the first few days after surgery, meal preparation is as simple as something as heating some food up in the microwave, but really being able to maximize your chances for a recovery and not being found in a situation where you needed help with something that you didn't realize you were going to need help with. So we talked a little bit about patient preparation for surgery. So now let's look at the healthcare team preparation. What are we doing on our side to help you prepare for your surgery? Because obviously there's a lot of stuff going on here and we want the best outcome possible. So I put this down as preoperative optimization, preoperative education, and some of the newer technologies, which I'll get into in a second. But preoperative optimization is the simple, not so simple, but the making sure that blood pressure is controlled if you have high blood pressure, making sure you're having a dental screening, making sure that you have, your heart's healthy, your lungs are healthy. So everybody really needs to be seen by the pre-anesthesia team, and everyone needs to be seen by their own primary care doctor. And if they don't have a primary care doctor, we can certainly get them plugged into one. But we want to make sure that every aspect of the patient's health is as optimal as possible to minimize risk. And along with that preoperative education, preoperative optimization also comes the preoperative education. We want you to know what to expect. We want you to, often you'll meet with physical therapists or occupational therapists to know what to expect after surgery, the first few days after surgery, all the way up to the months after surgery, what phases of physical therapy or occupational therapy are involved and what you will be doing through each of the phases. So I can't emphasize enough how important it is for people to be educated before their surgery. Some of the newer technologies. Well, the first one I'm going to talk about is Force, and this is really just a great addition to our platform. And it's through a company called Force Therapeutics. I'm sure there's many of them out there. But essentially, it's right here is what it says is it allows you to stay connected with our team. We have 2 nurse coordinators, which are monitor our platform. And this allows questions to be answered or either through an app on a cell phone or online. You can log in, you can send pictures back and forth, you can ask simple questions, and it allows us to keep better track of patients and also allows patients to feel like they're getting their needs and their questions addressed in a more timely fashion. I want to just share with you one of the really interesting things, and hopefully it's still up. I'm going to see if I can pull this up. So hopefully you can see this, but along the lines of preoperative preparation, what goes along on our side, well, this is an example of a 3-dimensional CAT scan of someone's shoulder. So what we're doing now, and this is different, and this is vastly different from how I used to do these shoulder surgeries just 5-10 years ago. But nowadays we're able to get 3-dimensional CAT scans of a patient. We're able to look to see where there might be bone cysts or where there might be wearing or what axis of rotation. And we're actually able to choose the implants and place them where we want to put them. So for example, here's a patient that I'm trying to plan. I am actually planning and doing their surgery virtually, and I can go ahead and move their socket. That just told me that I moved it a little too far. Once I have the socket in a good position, I can make sure it's flush on the bone. Again, that's a little too far. I can go ahead and choose the appropriate size implant and place it where I need to put it. As you can see here, you can move it in different spots. And once that's done, this is the socket side. If I like this, I can select this. I can move over to the humerus side for the patient, and I can select the right size humeral head. I can put the humeral head where I think it needs to go. And then with this technology, I can actually range the joint, see what it looks like, check it, and then we can finalize the plan, and I can generate a guide. And that guide actually allows me to put the instruments and the components exactly where I did on the computer, And as you can see on the screen here, it's actually gonna, hopefully it'll work, but it actually will generate a guide. And then that guide fits the patient's socket perfectly. And then a 3D printed mold of the patient's socket that is sterile, along with this guide, will come the day of surgery and allow me to put the implants exactly like they were put during the preoperative planning, to allow much better accuracy than we used to have. So big change in technology in terms of newer technologies. So, but I don't want to keep going on that. I find that stuff fascinating. I could do that stuff for hours. Expectations. So the recovery of shoulder replacements. Well, in general, you will be in a sling for 1 to 3 weeks. It's variable. Some people need a sling for as little as 5 days. Some people are out of it as quick as a week. And then some people need a sling for 4 weeks. So, but in general, you're in a sling for about 1 to 3 weeks. We will, depending on whether you had a regular shoulder replacement or a reverse shoulder replacement, we will protect certain ranges of motion in order to protect certain aspects of the surgery. And again, the physical therapist is educated on this and is constantly re-educating the patient on what they can and cannot do. Physical therapy in general starts within just a few days of surgery, I tell people to expect a 3 to 6 month recovery. As you can imagine, not everybody out there is the same. Everybody's out there at different phases of their life, different phases, and in terms of arthritis, and people recover differently. But I tell people about a 3 to 6 month recovery. I also tell people that you can, that during that time period, you can expect the bulk of your recovery, but you can expect to see improvements all the way up to a year after surgery. What to expect? So let's just talk a little bit about the longevity of these shoulder replacements and reverse shoulder replacements, and what you can expect in terms of how long are these things going to last. In general, well over 90% of people report significant pain relief from shoulder replacements, as well as reverse shoulder replacements. The total shoulder replacement, the data we have, that's older data because we had to follow it for 20 years in order to get these numbers, but the overall lasts 15 to 20 years. So 90% of them have survived and are doing well at 10 years, and about 80% at 20 years. These are more or less the general numbers. One thing to keep in mind is that in order to say we have certain survivorship rates at 20 years out, that means you're looking at the way things were done 20 years ago. Well, as you can see from the slides I just showed you earlier, in terms of newer technologies, we're doing things drastically different. So we're expecting that the shoulders we're putting in today with the newer technology we're using today, not only in terms of accuracy of placement, but also in terms of the wear and tear properties of the materials we're using, we're expecting these numbers to be just as good or better in the future. I hope some of you guys remember these TV shows out there, some of the best TV shows. So reverse shoulder replacements. The newer literature out there is about the same as the total shoulder replacements, about 90% at 10 years. And please, when we talk about their survivorship, we're talking about the survivorship of the prosthesis. So we're not talking about the survivorship of the patient. So the newer literature suggests about 90% at 10 years, and again, about 85% at 15 years, and about 80% at 20 years. And we expect to see continued pain relief and function all the way up to 10, 15 years after surgery. And my personal experience is by and large, I'm seeing that in the bulk of my patient population without question. So what can you do? What can you do after you've had your shoulder replaced? Whether it be a total shoulder replacement or a reverse shoulder replacement, these are generally the things that I allow everybody to do. You might see some variability in different shoulder surgeons and what they will allow and not allow people to do. But in general, all the things you see here on the left, golf, swimming, tennis, skiing, rowing, basketball. So I allow people to do all that, and I really get very little feedback that people can't do it. What I tell people to avoid, obviously the two big red X's. I don't like to see significant vibrating forces on an implant. As you can imagine, these things are put into place. You don't want to have them jar themselves loose over time. So a sudden kickback of a rifle, like a powerful rifle like you see in the lower right there. In general, about a 25 to 40 pound weight limit, again, depending on the size and the strength of a patient, in terms of activity away from the body. So things in close, lifting close, really don't have any limitations there, but 25 to 40 pounds of lifting away from the body tends to be where I tell people they should limit their activities in terms of weight resistance. So time for our final polling question. Are you a current patient of ours? That just helps us to reach out to those who we feel we might need to reach out to. So that would be helpful if you could fill out that question. And at this point, I think we are ready to switch to any questions and answers. Again, Priti and Sam, thank you so much for doing this. I do want to make one final, completely off the topic comment, and that is regarding COVID in our community, particularly in Berkshire County. Everybody out there is doing a fantastic job. I'm not wearing a mask right now. I'm alone in my office, but I just want to commend everybody out there in the community. We are doing extremely well here in our county. We are doing extremely well here in our facility and in Berkshire Medical Center, and our numbers are as good as you are hearing. So everybody keep up the good work, and I wish everybody a happy and healthy existence during these tough times. So are there any questions? I'm going to switch over to a question and answer page and see if there's any questions and answers. Again, I apologize if I spoke too quickly or too slowly. This is my first time doing this, so by all means, I am fully open to any feedback that anybody might have or any questions. I'm going to click on the question and answer tab here.
This is Preeti Shah. Before we go to the questions and answers, we are going to share the polling results from the first two questions. And for the audience, you can see the button at the bottom which says Q&A. You can type in your questions there. So please send your questions to us. Thank you.
This is Sam. I'm just going to give the polling probably another second or two, and then we'll start sharing all three of them. Poll number one's up. We got 78% for yes, 22% for no.
So this is really telling that we have quite a few people who are suffering from shoulder pain for one or the other reason. Thank you.
And poll number two, we had 26% for yes. They have been told that they will need surgery or joint replacement for their shoulder. 69% had said no, and 6% were unsure. Poll number 3, are you a current patient of Berkshire Orthopaedic Associates? 51% said yes, 49% said no. All right, Dr. Sprague, if you want to go ahead with the Q&A.
Great, thank you. So let's see here. First question I have here is, what kind of limitations could I possibly have once I have recovered from surgery? So limitations in general, like I mentioned, you want to limit the amount of weight you lift away from your body. We don't want to have any of these prostheses prematurely loosen. So you want to limit yourself from any sudden jarring activities. Obviously, high risk activities that put you at risk for falling onto an artificial joint, any artificial joint, we like to avoid. So high risk for fall activities, lifting more than 25 to 40 pounds. Again, that's about a 15-pound range, but it depends on the size and the muscle bulk of the person's deltoid. So limitations of 25 to 40 pounds away from the body are essentially what I tell people to avoid. But I have plenty of people that, you know, they understand the risks and they're still skiers or they're still whatever, and they prefer to keep doing that. Second question I have here, I hope you guys can still hear me okay. How long does it take to perform a shoulder surgery? So shoulder replacements and reverse shoulder replacements, I do some as quick as 1 hour and some take 3 hours. It all depends on how involved that person's shoulder is, how big that person is, how complex their disease is. So anywhere, I'm going to say anywhere from as little as just under an hour to over 3 hours. But on average, I would say they take about an hour, hour and a half. The next question, what are the most common complications? And that's a great question. And I am so sorry that I didn't bring those up. So when we talk about risks of surgery, let's talk first about risks and let's talk about complications. And thank you for that question. And I apologize, I didn't have that on my presentation. I'll do that next time. But when we talk about risks of surgery, in general, we like to talk about the risks that are relevant to the surgery, right? I mean, there's a million risks out there, and the reality of someone passing away during a surgery like this, or having a stroke, or having a heart attack, is extremely low. Way less than 0.5%. You probably even lower than that, and that's because we make sure through our team we do such a good preoperative screening process. But the relative risks, and again, I will get to complications in a second. The relative risks are, it can get infected. And about 1 to 3% in that range of all artificial joints will get infected at some point in the patient's lifetime. So it doesn't necessarily have to happen right after surgery. Someone can have an uneventful joint replacement and 5 years later have a dental abscess or a urinary tract infection, or some reason that an infection makes it into their body, and it can then seed the artificial joint. And if that does happen, it's a big deal. It often involves repeat surgery and prolonged antibiotics for several weeks. So that is a risk of joint replacement surgery, about 1 to 3%. Loosening of the joint. So when I talk about survivorship of that joint and we talk about limitations and things we like to avoid, they're because we don't want that joint, that artificial joint, to become loose over time. And that's the most common reason why people fail over time, is the joint can become loose. Just like anything mechanical in life can kind of loosen over time, so can joint replacements. Specific to the regular total shoulder replacement, the glenoid component is the one that we worry about loosening. The loosening on the humerus side is very rare, but loosening of the glenoid component on the total shoulder. And specifically to the reverse shoulder replacement, we have an added risk of what we call dislocation, because as you can see, we created a ball and socket there. So that's a known complication that can happen. It's rare. probably way less than 3%, but a dislocation of the reverse shoulder can happen. People that have rotator cuff that's borderline and they have a regular shoulder replacement, well, then their rotator cuff can fail at, years after their total shoulder replacement, so that can happen. So those are the things that, infection, loosening of the components, dislocation of the components, or a fall and a fracture around the component. Those are the most common types of complications that you can see. Sometimes you'll see a little bit of postoperative stiffness, but if you get plugged into physical therapy, postoperative stiffness is quite rare. So I talked about the risks, I talked about the complications. Next question I see here is, how long can I expect my stay to be in the hospital after I've had surgery? Great question, thank you very much. About 90%, 95% of people are going home either the same day or the next morning after surgery. And a lot of that depends on what we talked about in terms of the resources available to the patient. But I talked to 3 patients today, and all 3 of them are going to be going home the same day of their surgery. And then some people that might need a little more help and don't have the resources that they need, they typically go home the day after surgery. So either the same day or the night after. The day after. Next question I see here, are there any creams that can be used to help ease pain? Also for avid knitters and crocheters with rotator cuff issues, any hints? What about specific exercises to help? So start with the first part, any creams? So yes, there's a million creams out there and you can certainly try them. The ones I've specifically heard some people have tried some of the CBD creams out there. I hear very mixed results from patients as to whether or not they get significant relief. Some swear by it, some say no. There are creams like arnica cream. That's you can buy that at any health food or most health food stores. You can get like an arnica cream. Again, I've heard very mixed things about that. I've had some people swear by them. So the CBD creams or the arnica creams. There's also things like Voltaren cream, which is essentially a cream with ibuprofen in it. So it's a topical ibuprofen. You can try those. But those are the top 3 that I probably hear people talk about the most and that probably most consistently give some positive results. The next part of this question said, for avid knitters and crocheters with rotator cuff issues, any hints? So I myself am not a knitter or crocheter, but I'm imagining you're talking about keeping your hands out just slightly elevated, or the constant motion going out to the side. Anything you can do to kind of keep your elbows into the in close to the body. My mantra that I tell people that are suffering with rotator cuff issues that where it's continuing to bother them is elbows in and palms up. So elbows in, palms up is a position where you're kind of taking your rotator cuff out of the equation. Once your elbows come up to the side and your palms start going down and you start reaching and doing things like that, that's when the rotator cuff is firing and being used. So the mantra I tell people is elbows in, palms up. And then specific exercises to help. So this is a great point, because a lot of people say, well, I don't understand, if my rotator cuff is diseased or hurt or partially torn, why am I stressing it? And that's essentially, we're trying to get the shoulder, we're trying to get the good parts of the shoulder to become stronger and help accommodate and help compensate for the weaker parts or the torn parts. So deltoid exercises, rotator cuff strengthening exercises. Also, there's a group of exercises we call isometric exercises. Iso meaning same, metric meaning distance. So an isometric exercise is when you actually fire a muscle to a joint without moving the joint. So isometric exercises, I find, are something, at least in the beginning, to really help people with these types of issues. But thank you. Those were excellent questions. I appreciate those. A next question I see here is, can it occur in just one shoulder? If you're saying can it occur, meaning Arthritis, sure, absolutely. And most of the time it does occur in just one shoulder, but it depends on the cause of arthritis. Certainly if it's a post-traumatic arthritis where you've had trauma to that shoulder in the past, and yes, it will occur in one shoulder, but yes, absolutely, it can occur in just one shoulder. Next question I see here. I have an inflamed facet joint, but also feel pain in the shoulder. Is this normal? Great question. So there's two areas in the body where we kind of see overlap, and one is neck shoulder and other is back hip, low back hip. And people will often come in and say, my shoulder is killing me. And with just a little more questioning and physical exam and their symptoms, even though they swear their pain is coming from their shoulder, the source is actually their neck. So I encourage you to certainly be examined by somebody, and there are things we can do to rule out the neck as the source of pain. But it is very, very common for shoulder pain to cause neck symptoms and neck pain or a neck pathology to cause shoulder symptoms. Thank you. That was a great question. Next question I see is, what limitations are there for range of motion for a reverse? I guess you mean for the reverse shoulder replacement. Great question. Wow, great questions tonight. I'm really impressed. So for the reverse shoulder, the general limitation in the newer designs is internal rotation. So reaching up the back. So in general, getting to your back pocket or to a belt loop in the back, not a problem. But getting to like a bra strap or the middle of the back, that tends to be a problem. And we're hoping with the newer designs and the newer technology that we can work that out. Next question here. At what point should someone choose surgery over shots? That's a tough one. So, I know a lot of times people are told they've been told that they need a joint replacement. And I kind of want to set the record straight on what a need is, right? So you don't ever need a joint replacement because it's not life and death. But everyone has a different line in the sand that they draw as to whether or not they can put up with it. But, and everyone has different activities that they want to continue to pursue. Some people absolutely refuse to give up certain activities, and they say, well, if I have to give up that activity, then forget it. So just, I want something done. In general, though, to kind of stop being so vague, in general, I think that when people lose the ability to have a good night's sleep or do simple activities of daily living, like getting dressed, feeding yourself, doing simple things, meal preparation, showering, any of those, when people lose the ability to do simple activities of daily living or getting a good night's sleep, that's often where people just say enough is enough and it's time to replace their joint. Next question I see here. What is the physical therapy process like after surgery? It's intensive. It's typically at least 1 to 3 days a week. If someone's a little bit stiffer, we'll get them in a little bit more frequently. If someone's having a little bit more of accelerated recovery, they'll be in a little less frequently. So we tell people that expect to be going to physical therapy anywhere from 1 to 3 times a week, or at least be doing those exercises several days a week for several months after surgery. As you get further away from surgery, you'll have less appointments and less time you need to devote to doing physical therapy, but it is a part-time job. It's a part-time job, the physical therapy process after surgery. I hope that helped. Next question. I've been told that I have a torn rotator cuff. It's under control right now. And that's the right shoulder. And now my left shoulder hurts, but it's tolerable. How do I differentiate between a torn rotator cuff and arthritis? Often you can't. Often you can as a patient. Certainly imaging, physical exam in general physical exam, imaging, and a history will help us differentiate the two. For you, in general, this is generally speaking, it's not always true, but in general, rotator cuff pain kind of comes down out the outside of the shoulder. People will often hold their hand here from that referred pain that comes down, and it'll hurt with things out, reaching and doing things away from their body. In general, so it'll be episodic and during those things, or after a period of overuse. Arthritis in general will feel more deep in the shoulder, often with a lot of pain in the back. You can have something called crepitus, where you feel like a catching or a grinding in the shoulder. But that question actually is a great question, and it's why we generally need to get screening x-rays on everybody that comes in the office, because they can mimic each other, and sometimes it is a little difficult to weed them out. Next question. If you have a serious rotator cuff tear, can you have a gel shot? So if you have arthritis, yes, but a gel shot is not indicated for a rotator cuff tear. The gel shots, or the artificial synovial fluid shots, are really for people that have worn out articular cartilage. For a reverse, how long are you in a sling? Anywhere from 1 to 3 weeks. Some people a little longer, but in general, 1 to 3 weeks. I can imagine having a shoulder surgery can be very painful. How will my pain be managed after the surgery? Excellent question. Thank you. So we do regional anesthesia, which is basically blocking the nerve supply to that shoulder, and that wears off by anywhere from 6 to 12 hours after surgery. We put a local anesthetic that lasts for up to 3 days after the surgery. We do what we call multimodal, so a little bit of narcotic, a little bit of anti-inflammatory as well. So it's kind of a multimodal approach that helps control the pain. And I can say that we've really come a long way with these different approaches and kind of using them all in terms of pain management. Is it possible to surgically clean the arthritic joint without placing it? Yeah, we get asked this all the time about, so when we talk about surgically cleaning an arthritic joint, that's really a term that's what we call debridement. And what we're doing when we go in there is we're washing out the joint, because if you can imagine, the synovial fluid in someone with an arthritic joint is not normal. So we're washing out their joint so that the body can then try to replace it with more normal synovial fluid. And then we're removing any loose cartilage that's already flaked off from the joint. But we don't actually go in and scrape away articular cartilage that's intact. That is, at best, a 50-50, I tell people, in terms of long-term relief. But if you remember back to what I was saying in terms of longevity of shoulders, you can kind of imagine the theme where we don't like to put shoulder replacements in people until they're at a point in their life where we imagine it's just going to work for them for the rest of their life. So your question brings up a very good point. Well, what about the 50-year-old who's got an arthritic joint? And that's the type of person where we feel an arthroscopic debridement of going in there arthroscopically and cleaning out the joint. That can hopefully buy them some time until they're old enough that they will make the decision to have the joint replacement, and then that will then last the rest of their life. As you can imagine, someone who's 50 years old and still working and still at a very, very active point in their life is different than a 75-year-old who might no longer be working, doesn't have the same level of activity and exertion they're putting on their shoulder. So if you put an artificial joint in a 50-year-old, well, then there's a chance they can wear out prematurely. So we reserve arthroscopic debridement and flushing out joints for people that fall into that younger category who we're trying to really do whatever we can to give them more time before an artificial joint. What exercises can I do daily to allocate the pain? Now I stretch and sleep on shoulder. So just like the exercises we talked about before, if the shoulder is quite painful, I would start with just the isometric exercises. Is there an age limit for surgery? No, there's not. When we talk about age, there's chronological age and there's physiological age, right? We all have friends and relatives that are 50 years old and they are in better shape than some 30-year-olds. So that's somebody who, even though they're chronologically 50, and that in today's day and age, that applies to 70-year-olds. We have people that are chronologically 70, but physiologically they're very, very fit. So as physicians, we tend to look more at the physiological age of the patient and where they are when we make these decisions. Next question, as with a knee replacement, are there pre-surgery exercises? Is this also true of shoulder surgery? Also, the force therapeutic site is wonderful. I have to agree. That's one of the best things that's happened for our patients is that force therapeutic site. It's great. Yes, there are exercises to do. There's some stretches you can do as well. In general, the stronger a joint is and the more flexible a joint is going into surgery, the healthier the joint is, so the better and the quicker the recovery is on the other side of surgery. Here's a great one. So how about a person with bone density problems? What would be the chance for surgery for that patient? Great question. Oftentimes we do see people that their bone density is so poor that we do have to either do a different type of replacement, maybe something what we call a hemiarthroplasty, because we'd be too worried about the socket side in the total shoulder or the ball side in a reverse shoulder loosening. So there's definitely expectation setting there. It is very rare that I'll get into a surgery and the bone will be so soft. There's usually that I have to make that decision intraoperatively. But it is a good point. It is something we are aware of and we do pay attention to. How about diclofenac sodium topical gel? That's the next question. Is that useful? It's sure, it is useful. If it's giving you some pain relief and it's allowing you to do the activities you want to do, then sure, by all means, try it. Don't break the bank on it and spend too much money on it. Give it a try. I will say that the diclofenac gels and any of those gels, they are an anti-inflammatory. They are an NSAID. So you can use too much of those and in essence have a negative effect on your kidneys because your body does absorb it. So if you're going to use those topical gels, make sure you only use them as directed. It's not just more and more and more, because there have been some cases of people that have had negative kidney, have had deleterious effects of their kidney by using too much of it. Just like any other medication, just make sure you follow the directions on that. But excellent question. Thanks. I appreciate it. Next question, are isometric exercises helpful before surgery? Yes, very much so. And what exercises can build up the deltoid muscle? So I reviewed with you in the general premise of what isometric exercises are. If you do a Google search and type that in, you can see the deltoid muscle. Essentially, I divide the deltoid muscle into three parts. There's the anterior deltoid, the front, the lateral deltoid on the side, and the posterior deltoid on the back. So pushing forward with a flexed elbow and your elbow at your side, pushing forward exercises the anterior deltoid, pushing out to the side exercises the lateral deltoid, and then sliding the elbow back. And if you do that against resistance, that's a great way to get really good muscle tone in your deltoid before surgery. And it brings up a good point, and I apologize I didn't mention this. I did mention in my talk about how the deltoid is very important for a successful reverse arthroplasty or reverse shoulder replacement. So we do test the deltoid. It's a quick and easy test I do in the office, but I do make sure that the patient has a functioning deltoid before we do a reverse shoulder replacement. But thanks for that question. That was great. How long before being able to dress yourself? I'm assuming you mean after surgery. And again, that kind of depends. Everybody's a little bit different. But right away. Within a week to two, you should be able to start doing things like dress yourself. The limitations that are placed on you for after shoulder replacement, both total and reverse, do not involve not being able to do simple things like dress yourself. The limitation will really be your discomfort and pain, but you won't be doing anything wrong or risky to your joint replacement by doing the simple things of dressing yourself. Again, like with the reverse, you do have limitations of reaching behind your back. So you kind of have to figure out either appropriate clothing to wear that you don't have to reach behind your back and like feed a belt through a loop, or appropriate clothing, or figure out little tips and tricks that people have, and often the occupational therapist can give people in order to help them do tasks that they're normally doing in a certain way. They have other ways that they teach you, and this is why preoperative education with those folks can be very, very helpful. Would an examination define arthritis or torn rotator cuff? Yes, but not always. Again, like I said earlier, that's why we always get a screening x-ray on people that come in with shoulder pain, because it's very, very helpful. And also the history is very, very helpful. So with the appropriate questions, the appropriate imaging, and the appropriate exam, then yes, 99% of the time we can figure out the difference between the two. Is MRI useful? Is MRI usually needed to define the problem and plan treatment? When we're talking about rotator cuff pathology, if you're in the realm of rotator cuff surgery, yes. If you're talking about joint replacement, no, not as much. I would probably say for people that I'm doing a reverse shoulder replacement on, between their regular films and their history and their examination, I almost never need an MRI. What I do get is that, like that 3-dimensional CAT scan you saw, I get one of those, and that's more for preoperative planning to look at the extent of the disease and where I'm going to be positioning the components. But for that population, no, in general, I don't need an MRI. If you have a rotator cuff tear and need a reverse, is diclofenac gel still helpful? Sure. Again, like I said earlier, the downside of trying it is so low, you can certainly try it. And by all means, you should, as long as, again, you follow the directions when you use it. Is physical, I like this question, I've had this one before, is physical therapy and or exercise weights a good idea in with an arthritic shoulder? So, and this is our last question, and I do appreciate these questions. These are great, but this is a good one. So if you have a joint where the cartilage is wearing out, and then you continue to move that, what I always tell patients, if you have brake pads of a car that are completely worn out, and you continue to drive the car and step on the brake, is it causing more damage? Yes, it often is. And that's why the isometric exercises, or a very, very gentle exercise program that doesn't cause significant pain, can be helpful. Strong muscles around an arthritic joint can help absorb some of the forces and can take some of the pain away. And that's theoretical, but I do find that it tends to be quite true for people. So a gentle exercise program for an arthritic joint, especially one that includes some mild to moderate stretches and also includes an isometric program, can be helpful. But I want to thank everybody for their time. It's 8 o'clock, and I want to thank you for the great questions. And I hope this was very helpful. Again, please give feedback. It would be greatly appreciated. This is my first time doing this, and I hope that I helped you answer some of your pressing questions. Have a good evening, everybody.
Just something else to note before we sign off, there is a post-webinar survey, so please be on the lookout to fill that out once you leave the webinar for us today. Thank you.
Have a good night, everybody.